Welcome to IMIT Seminars. We created this space to help MSK specialists immediately impact their patients, businesses, and personal lives through relevant discussions and practical insights. Let's jump on in. Hey everybody, welcome to episode 1. My name is Dr. Sean Flanagan. I'm here with my co-hosts, Dr. Matt and Rachel Grubb. Today we're going to be talking to our good friend from across the pond, Mr. Jon Hobbs, the founder of the Hobbs Masters Needling Series. And today, John's going to be discussing with us the 5 reasons you may clinically reason to use dry needling within a treatment session. Guys, Matt, Rachel, I am thoroughly excited about this episode because what I know is that John's influence and mentoring in my life has drastically changed my clinical reasoning around when I use dry needling. So Matt, before we get started and you introduce John, would the two of you mind sharing how John's influence and mentoring has impacted how you look at and view patients when it comes to dry needling?
Thanks, Sean. Good to be here. Super excited to be able to bring you this first installment of just what we're kind of calling our Clinician's Corner. To be able, we can talk about some practical issues about what we can do to try to help clinicians up their game, whether it be business tips or whether it be clinical management, ideas surrounding reimbursement, whatever it is. We just really want this to be a really broad-based and welcome place for clinicians to be able to kind of talk about some stuff. And you're right, I'm really, really excited to be able to have John be on with us in this first episode because he's a colleague, he's a friend, he's been a mentor for us over the last few years, and really just John's been doing this now for decades, both the education and the clinical practice, and being a man who's had a lot of really, really solid and expansive expertise in the field of physiotherapy and being able to incorporate needling practices into that as well, and being able to really teach this in a way that's almost revolutionary in its simplicity. You know, I think the thing that John really has kind of imparted to me in my own clinical practice has really been the as much as necessary, but really it's the little as possible in order to bring about optimal therapeutic outcomes. And it was that just really kind of opened my eyes to a different game, a bigger game, you know, kind of within needling construct, and be able to manage patients who had pain and had musculoskeletal dysfunction. And so I think from that perspective, John just really has opened a lot of doors and really changed the way that I've thought about clinical reasoning and applying needling to a client who may potentially need it. So really, really love John's perspective, and just, again, simple sometimes is better. And so I would like to take a second, though, to introduce the other part of the Grubb duo, my substantially better half, Dr. Rachel Grubb, who will be sharing some similar perspectives on John. So Rachel, take it away.
I'm happy to be here. I'm looking forward to John's talk today. He helped me the most in knowing how to adjust my treatment if the initial session of needling didn't go as I expected. It was his attention to detail and dosage and matching the needling intervention to what that patient needed at that time and being able to see it through a different lens. So I'm really looking forward to it today. Back to you, Matt.
All right, Rachel, thanks for those words. Really appreciate it. And without further ado, the reason that you guys tuned in today is not to listen to me, it's to listen to the guy with the cool accent who makes everything sound better, Mr. Jon Hobbs. Thanks, John.
Okay, Matt, thanks for that. Thanks for saying those kind words anyway. So I suppose where to start really with this. One of the things I've noticed, with needling education generally, and I think my journey when I was taught originally probably fell into this as well, is that we can fall into the trap of becoming very prescriptive with treatment. So people ask me, well, what would I do about this condition or that condition? And what people want is a standardized set of points normally, and I understand that when you start, and I will give people those prescriptions when I start, but I also want to plant those seeds of thinking about clinical reasoning, how you move away from that as well. For example, if somebody says to me, well, how do I treat tennis elbow? What they're looking for is just a list of prescription points. And I see on a lot of educational programs that's given, and that's okay to start with. There's nothing wrong with that. But the issue then comes with, well, what if that isn't the sort of tennis elbow that you think it is? When you're using an umbrella term to describe a problem like that, the issue then comes is, what's the mechanism behind it? What's the pathophysiology? So some of the things that I talk about is thinking about, well, what's the pathophysiology of a problem? and what's the mechanism, the modality, and how do these fit together. So to come up with some ideas about how to needle and how to needle effectively, you have to start with perhaps really good subjective, and then a really good objective, and that leads to good clinical reasoning, and then that leads to a good use of needling. But then it comes down to, well, how does needling work? Because if it has to fit in with the pathophysiology of the problem, you have to have some understanding of how you're going to use it. So a couple of things I always talk about is, I think, and Matt mentioned earlier in his introduction about things like Monday morning techniques. So what you're going to do on a Monday morning when you get into clinic. I'll also add to that the idea of N equals 1, that a patient's an individual, and prescriptions work to a degree, which is great. But there's also maybe that 20% that prescriptions aren't really going to work for. So then you need to think a little bit clearer about the issue and decide how you're going to use needling to resolve those issues. So I suppose from my perspective, from a clinical perspective, over, as Matt kindly said, over a number of decades, and over sort of teaching, particularly more recent years, I think more about how to encapsulate these ideas, not only for students when I'm teaching, but also for myself in clinic. So I'm always thinking about these issues when I'm treating somebody. I'm always thinking about, well, what's really going on with this problem? Have I diagnosed this accurately? Am I getting to the core of the problem? Am I addressing those key components? So to make this very simple, you guys, whatever level you're needling, whether you're new to it or whether you've been doing it for some years, what I'd say to think about is the 5 main reasons why you want to needle. So for me, there's 5 things I want to think about when I'm needling somebody. And regardless of the presentation, whether it's a localized problem or whether it's radiculopathic, whether it's a central problem, whether it's just pain, or whether there's myofascial mechanical dysfunction, I'm thinking about how I utilize needling. And probably my, not criticism, but critique of some approaches to needling is they don't necessarily encompass all of these 5 ideas. And I often find that they're not discussed in this manner if they do. And so what I like to do is make things really, really simple for myself and for anyone I'm working with. So I'm going to break down these really simple 5 ideas for you. And I think that's a useful place to start, really, with these discussions, with these notes on needling, really. Because if you've got these 5 ideas in your head, you can tackle any problem. Really, it doesn't matter whether you've seen this problem before. And people come to me all the time, colleagues, ex-students. I get approached all the time about how to solve problems. And some of the things I actually do is I actually consult for other physios. I consult for physios who work in elite sport, for Team GB, in professional football, so soccer, Premiership soccer over here. I've got to say Premiership football. Also, when I've done work in the US with NFL and with the military here and in the US as well, people ask me questions about what do I do about this. And so the first question I ask when somebody says to me, can I use needling for this problem? The question I ask then is, well, how does it present? And what I want to do then is I want to understand what's the pathophysiological presentation, because once I understand what that presentation is, not just the diagnosis, but how does it actually present? Because once I understand that, we can start to understand how needling fits into that and how these mechanisms can interplay with the condition and therefore address those physiological components. Because if we can address those, we can treat it, we can change it, we can alter it. Two of the things that I always say is very important as a clinician to understand, particularly if you're a physical therapist, 2 of the most important things to understand are physics and physiology. They're 2 of the things that you can't change. But by understanding how they work from an exercise, from manual therapy, from a needling perspective, if you understand that, then you can utilize the interplay with your intervention with those to get better outcomes and improve your outcomes. So without me going on anymore, let's talk about these 5 things. So the first reason to think about needling somebody is the the local trauma response. So when you insert a needle, wherever you insert it, you can get trauma. Trauma is going to give you inflammation. So it's going to give you heat, redness, pain, swelling, and altered function. And that's going to give you a release of certain chemical responses like calcitonin gene-related peptide, nitric oxide, nerve growth factor, and so on. And these are going to affect healing responses, tissue responses. So if you've got trauma in that area, it can be useful to needle to get the stimulus of an inflammatory response, and that will spread a couple of centimeters around the needle. So it can be useful to get that to accelerate wound healing. If you're dealing with something like physical sort of trauma to the muscle, to even to the skin, if it's abrasions to the skin, even stress fractures, it can be useful to think about needling around those to create that inflammatory and healing response. Initially, you'll get vasodilation, but repeated needle will also bring about angiogenesis, which can be useful for wound healing. Release of NGF as well can be beneficial to modify the healing response as well, and some studies have shown that can improve outcomes with tissue healing, and that's obviously released when we needle. So think about that local effect. If you don't want inflammation in the area, don't stick the needle where the problem is. If you do, then put some needles around there. And when we think about how close we need to be, as long as you're within a couple of centimeters, it should be fine. I'd also think in those instances about needling what are considered to be traditional acupuncture points, and that's a little bit, I know, controversial in the world of dry needling, but the reason that certain points exist in their locations is because they have a physiological response, and the physiological response could be greater in some areas than it is in others. But wherever we needle, we'll get this local inflammatory reaction, which can give us a healing response. So the first reason I'll be thinking is, well, do I want local tissue healing? If I do, think about inserting a needle in there. The second thing I would think about would be the analgesic response. Is there pain in that area? And in most cases, if there's myofascial injury, there's going to be pain. So it can be useful to needle that area for the local opioid response, the local adenosine response. We can get adenosine binding to C fibers to inhibit pain transmission to a greater or lesser degree. We can get a local opioid response. So it can be useful to needle locally for that response as well. So do we want to put a needle where the problem is? So yeah, that's the second reason I'd be thinking. The third one would be the myofascial effect or the mechanical responses. Is there are there trigger points? Is there myofascial tightness? Remember, myofascial pain is going to be associated with myofascial tightness. So do we want a needle for that respect? That can be quite useful. Is there a mechanical problem? Is there an issue with loading, range of movement, function? We could be looking at something like addressing the mechanics of the shoulder. It could be a mechanical dysfunction. It could be post-operative. It could be post-injury. It could be reasons to needle around that shoulder. And if there is, then it's useful to needle from a mechanical perspective. How close do we need to be? Well, really, in this instance, we need to be near those motor points, those motor terminals, where that integration of the neurology is with the muscular structure. So we've got that level of innervation, and that's where we'll find the majority of those trigger points, as described historically by Travell and Simons way back when. We're going back to the 1940s onwards since they're starting to map those out. And there's been lots of work on those ever since to, confirming, denying all sorts of ideas about those. But really, if we think about myofascial effect, it isn't just place it in the muscle. We want to think about those motor points. And when we're thinking about those, depending on the evidence that you look at, somewhere between 70 and 90% of those are going to be in the area of traditional acupuncture points. Big crossover between those ideas, those theories. Because the points are located for perhaps two main reasons. One, they have an effect. Two, they miss everything that's important. Because if you want to have an effect, you need to be near neurovascular structures, which means you want the sensitivity and reactivity of that response in the tissue, but you don't want to hit those structures. So anatomy, point location becomes very important, particularly for that myofascial effect, where people start to go a little bit more off-piste and start to kind of freestyle their needling a little bit more. It's okay to do that, but you need to think very carefully about that three-dimensional anatomy. You want to be close enough to a neurovascular structure to affect a change, so you want that force multiplier of response, but you don't want to be close enough to hit it. So that's not, that's not a great idea. The fourth reason I would needle is segmental analgesia and segmental responses. And so this idea is that we're going to get an analgesic response by being within the segment. Now, the interesting thing about segment, and here we're talking about dermatomes or myotomes, we could be talking about sclerotomes as well, and getting right down there into that deeper connective tissue and into periosteal structures. We could be, but if we stick primarily with the idea of dermatomes and myotomes, and within that perhaps even more so myotomes, we can think about having a segmental response. If we're needling local to the problem, by default we'd be segmental anyway, but we could also move out of that and be segmental higher and lower along the segment, or perhaps I should say more proximal and more distal along the segment. But what's interesting about that is when we look at the evidence for certain locations, it's key areas within those segments that are important. It isn't just the segment generally, it's location within that. And what I'll do after I talk about these 5 reasons, I'm just going to recap how accurate you need to be with your needling, because that varies a few moments afterwards. So being segmental. The other thing to consider as well, and I find that this isn't touched upon so much on some courses, but what I like to do is I like to introduce this to MSK practitioners, because it's just about anatomy and physiology, but the concept that it isn't just about dermatomes and myotomes. When we're talking about segment, we've also got to consider the viscerotomes as well, so the innervation into organs. And there's some very interesting research and very interesting evidence on the effect of needling on viscerotomes, because this opens a whole new kind of sort of canon of treatment, really. And this enables you to interact with more visceral problems, such as bowel and bladder dysfunctions, which fall into the realms of physical therapy, particularly when you get into management of sort of women's or pelvic health, and some huge responses and huge effects you can have on these sorts of dysfunctions. And in turn, these affect lifestyle, these affect well-being, they affect MSK, they affect musculoskeletal. So some really interesting things. Probably next time I'm in the States, so I'm hoping to deliver some face-to-face workshops on that. And if any of you guys are interested in that, just get in touch with me, because I always like to talk about those other mechanisms as well. Everyone thinks about pain, but there's so much more you can do, which is one of the great things about it. And that starts with the segmental. It gets even more so when we get onto this 5th reason. And again, this is one I find that a lot of people don't touch on and don't investigate so much. And perhaps when I get onto this one, I know some people might have opinions on this. It may raise some eyebrows, and that's okay. One of the things I always say when I'm teaching is you don't need to agree with me. It's fine to disagree with me. All I'm going to ask you to do is entertain the idea. There's a quote that's attributed to Aristotle, which is, and I'll paraphrase a little bit here, but it's a sign of intelligence is the ability to entertain an idea without accepting it. All I'm going to ask you to do is to entertain it. You don't need to accept it, but you do need to entertain it, because once you entertain an idea and you start to explore it and you start to play it round and you start to look at in this setting, you start to look at the mechanisms, the physiology and the evidence, some interesting things you can find. If you're fixed on the idea that it's all just about local, it's just about myofascial release, it's just about the MSK, you're going to miss a huge perspective of change that you can make. And again, this kind of goes to what Matt was sort of alluding to earlier, which is also the subtleties of needling. how we influence sympathetic, parasympathetic response. If your needling is very, don't want to say aggressive, but if your needling is very strong all the time, you're constantly pushing a sympathetic agenda with your needling. And sometimes you need to drive a parasympathetic one. And that's some of the work that I do in elite sport when I want to talk about healing and recovery and elevating performance. It's not about the harsh needling, it's actually about the subtleties, which a lot of people miss. And so if you're interested in elevating that aspect of your needling, again, that's something I'd love to talk about later on, but we'll just touch on it for a moment here. Central effect. So needling predominantly in the peripheries, perhaps away from the musculoskeletal problem, to influence those central responses, autonomic regulations. So you think about sympathetic, parasympathetic responses, descending opioid effects, influencing ACTH, so influencing cortisol in the body, and that affects everything from healing to sleep to digestion to recovery, to anxiety to depression. The layers that you can achieve with the central effects are as many as the layers of problems that people can suffer and endure anyway. So it's a useful tool. So those 5 reasons recapped. 1, local inflammatory response. So if you've got a problem you want it to heal, think about needling. Think about needling in the area. If you've got pain in that area, think about needling that area because of local opioid response. If you've got some mechanical dysfunction, some myofascial dysfunction, think about needling in the locale, particularly the muscles in that area, particularly those muscles loading upon perhaps the loaded structures. Think about segmental analgesia and segmental responses. And for those, you need to think about your location in the segment and central responses. So those tend to be in the peripheries, which people struggle with a little bit. When you start to needle peripherally, people start to think about, that they're stepping out of their wheelhouse a little bit. But let's not get confused here. I'm not talking traditional acupuncture in any of these settings here. I'm not talking sandals and candles. I'm talking anatomy and physiology. I'm talking about pathophysiology. I'm talking about a mechanistic approach to solving problems. So whilst we've got those 5 reasons to needle, just going to add to that another layer, which is how accurate do you need to be? Because this is a question I get asked all the time. How close do I need to be when I'm needling? Am I looking for a specific trigger point? Am I looking for a specific point related, like a motor point, or am I looking for a fascial point? And people call them all sorts of different things. But basically, if you're thinking about the first reason to needle, where do you need to be? Within a couple of centimeters of the problem. You need to be close to it because that inflammatory response is only going to spread so far. Local opioid response, where do I need to be? Well, within a couple of centimeters. But also, if you can locate this perineurally, if you can place yourself next to a key neurovascular structure, so adjacent to it without being in it, and it isn't every single one, it's in certain areas where these structures become more superficial. If you can locate somewhere near to those, you're going to increase that opioid response in that area. You get a force multiplier in a sense. So you need to be fairly close with that. The reason being is, 1, you need to be close for the functional effect, but you also need to avoid the actual structure that is driving the effect as well. You don't want to be needling the neurovascular structure. So close, but not in. Myofascial effect, how close do you need to be? In the muscle, in the trigger point, which is a motor point, which means that you need to be somewhere close to that innervation as well. So that's actually much more specific than most people think. It isn't as random as I hear it talked about sometimes. Yes, of course, you can needle anywhere in the muscle. The caveat of anywhere is providing you know what's underneath the needle. Providing you understand your 3-dimensional anatomy, you can needle anywhere. If you don't, go where you're directed to go. 4th reason, segmental. In the segment, obviously, but it isn't as simple as that. You need to be perineural in the segment, and you need to be perineural next to a specific structure, not just any perineural structure. Very specific. And I talk about these, and I talk a lot about anatomy and point location when I'm teaching, and I show guys very quick, easy ways to find structures, to break the anatomy down, very quick anatomy 101s, how to find the structure, how to find the point, how to get an effect. Very quick Monday morning techniques. And then on that last reason, centrally, you want that central effect, you want systemic effects, you want sympathetic effects, parasympathetic effects, autonomic regulation, descending opioid, ACTH. Where do you need to be? You need to be peripheral, normally. Hands, feet, knees, and elbows. Those are your big areas. Those are your big hitters. And where do you need to be in those? You need to be perineural. But it matters exactly, again, whereabouts. It isn't random. You need to be in specific areas. And those are the things that I teach, how to optimize your outcomes. So that's probably a little bit longer than you wanted, but that's a very abridged version of how I would think about needling and how close you need to be to a point relative to those ideas. So that's where guys need to be thinking when it comes to treating. That's just a little note on that sort of needling. Any questions?
Jon, I'm sure we're going to have a ton of questions as people start to process through this. If you do have questions, please put them in the comments below. We will make sure we get back to all of them and maybe even talk about them on a future broadcast. As I was reflecting on this and really thinking about even my initial dive into dry needling, I left kind of frustrated because a lot of my initial training was around semi-standard protocols, and I tended to treat conditions versus patients. Every carpal tunnel syndrome or every cervicogenic headache or every low back patient got the same setup, and it all looked kind of the same. So what happened is that you actually kind of challenged me to clinically reason through both optimal dosage as well as what was the purpose of each needle within that patient presentation. And as I think about it now and reflect back on it, it resulted in me not overcooking patients as much, as well as even being more conservative in my needling and needling less and loading faster. So it's kind of exciting to kind of see my own growth process in this as I had taken a lot of needling here in the United States. I love how Matt kind of puts it. He says that the easiest part of needling is putting the needle in the body, but it's really the why or the background story behind why we're doing what with each needle that really adds layers to our clinical reasoning and our effectiveness. And for me, it's the same way I think about like manipulation. Like manipulation isn't magic, and it's really easy to teach people to do. It's a lot harder to teach them when not to do it, and when to do it appropriately within that patient presentation. That's what makes the world of difference. And we've proven in Cod Ed world right now that it's really easy to create click it and stick it type of practitioners, and that's just not what we're trying to do here. So it takes a lot more to be mindful and deliberate in your treatment strategies, and that takes a lot more intentionality. And I think that's why I really gravitate towards what you teach and how to clinically reason when it comes to utilizing needles with patients.
Definition of optimum dose is the minimum required to get the desired result. If you can get, what's the minimum you can do? And that sounds lazy, but what's the minimum you can do to solve the problem? Because that's what it's all about, whether it's exercise, manual therapy, advice, needling. It isn't just about needling. The clinical reasoning that I use is the same clinical reasoning I would use for exercise, for manual therapy. And the things that I teach as far as anatomy, physiology, reasoning, the whole things, they're not about needling. They're about treating. And it's just, obviously I'm talking about needling, so this is where it fits in, but it would fit with any approach.
Guys, that was amazing, Jon. Thanks for your time, and I look forward to doing this on almost a weekly basis. I think that's what we got planned out for the rest of the year, so really looking forward to it, Jon, and just thank you for taking your time. I know it's we're about 8 hours difference, so carving this out is huge for everybody.
That's great. I appreciate it. Thank you. I'm happy to come back anytime and talk about some more things.
I'm really excited for this upcoming week. We're going to be talking about tendinopathies, and then if you will go to IMED seminars and go to our dates and locations, you'll see that John's going to be over here in November. He's going to be both in Atlanta, November 6th and 7th, and then he'll be over here in Phoenix for the next 2 weeks. He's going to do his pelvic health management course both in Atlanta and Phoenix, as well as his sports course in Phoenix. So go to our website, check those out. We definitely have some DIN 1 and 2 courses to get some foundations in if you're looking to start your journey. But John, Matt, Rachel, thanks for joining us today. Everybody, we'll see you next week as we dive into tendinopathies and dry needling.